So second session is about pathological finding. So we will talk about 13 pathology. These are bowel thickness, which is thinness and thickness. And then we'll talk about peristalsis. And we'll talk about color Doppler and different types and signs of bowel sickness abnormalities. We'll talk about intramural gas and portal venous gas. And then we'll talk about intraperitoneal gas and fluid. So first we'll start with the bowel thickness and also peristalsis and bowel wall Doppler. The thickness, the normal thickness, comes only from one study. So it's not absolutely accurate. And it's maybe variable with different gestation. But if the thickness is more than 2.6 is considered, or it's more than 2.5 or 2.6 and more, considered abnormal. And if it's less than 1.1 millimeter or 0.11 centimeter on the window of your screen, when you do the ultrasound, the scale will be either on the right or on the left. This is considered abnormal. Now, the abnormality are not taken alone, they are mixed abnormalities. So when you see thinness and there is nothing else, probably this is variation of normal. But if it's associated with other abnormality, then consider that this is might be. So this is a highly magnified picture where you can see the bowel and you can see dots of air. You can see fluid and some other turbid materials. You can see the normal wall. Again, you can see dots of air inside the bowel. You can see here start to being thick. Okay. And you can see also here thick and start to be separated, become sloughed. And you can see the color of the bowel change. And here is already sloughed. And probably air is ready to escape. And you can see also here is increase the thickness. Okay, so when it's thin, mean it's being sloughed. Some of the bowel are dead and being sloughed. And when it becomes thick, it means edema, hemorrhage, and inflammation. And always you can measure. And remember not to take it separate because the normal comes from only one study.
Okay. So I can see the normal and the abnormal and all in one.
You can see all in one, usually not the whole wall, unless if the whole wall are sick, it's very late sign. But most of the time you don't see it all in one bowel wall.
Okay.
And best to do the assessment when you take a cross section of a bowel. Because when you do ultrasound, you'll see the bowels in cross section, in oblique, and sometimes in longitudinal section. So because they're moving in different directions. So just try to measure the thickness in a cross section bowel wall. And this is description to what we've said right now. And from where it comes and why there is thickness or thinness.
Okay.
And this is again the normal when it becomes more than 2 millimeter, you consider it suspicious and you consider it abnormal when it's more than 2.5. When you try to see the air or peristalsis, try to make the lowest possible, whether it's colored or it's 2D. So you go to the lowest possible you can see, decrease your contrast to as much as possible. There will be an ultrasound, something called gain, depth, magnification. Yes. There is no that. So you go to the contrast as low as you can, and then look to your and try to make the highest gain you can and the lowest contrast you can, and then to evaluate the bowel wall peristalsis, also the color Doppler, and also the bowel thickness.
Yeah.
When you assess the bowel wall peristalsis and you have suspicion, then put the color Doppler on it. And if there is a color Doppler, usually there is some sort of bowel wall or bowel content peristalsis. You can see here is very minimal movement, but there is movement of the bowel. You can see that here you can measure this very small bowel, but you can see you can measure the thickness. You can magnify it and measure the thickness.
Yep.
And you can see how the bowel are moving. So this is, I consider that the wall is moving, the content is moving, not only that, everything in this picture is moving. So I would consider this bowel wall movement, yeah, and also the thickness mostly normal, yeah. So if we can measure this, you can see this, okay?
Yeah.
And if you feel that there is thinness, probably keep the bowel moving to see if this some kind of artifact or it's a real change in the bowel wall. And always, as I say, if you see thinness or thickness, don't take it alone. Take it with other features, because most of the time, if the bowel wall is moving and there is thinness or thickness, then probably either this is an artifact or not correct sectioning of the bowel by the ultrasound.
Okay.
Yeah, regarding the Doppler, as I told you, the study came from Fane Gold from Ontario, who did a study on 26 babies. And then he compared this with these 26 babies ended up doing surgery. And then he compared it with the macroscopic view by the surgeon and also histopathological if the histopathology was done. And he concluded that there is hyperemic and hyporemic face. And he used a pulse Doppler and he put the gate, if you remember the gate, at 0.029 millisecond. And if you do that at 0.029 millisecond, then if you only find 1 to 9 color Doppler signal, then probably this is normal. The mean of the number is 3.8, so the mean is between 3 and 8 of the normal. But down to 1, up to 9 also considered normal. More than 9, he considered it hyperemic, and less than 1 considered it hyporemic. And again, this is a study, okay? And remember to control the window, the gate of the Doppler ultrasound, of the pulse, because this is used in only pulse. I mean, that's when he concentrate on one view. And you can see this bowel here. If you can see this bowel here, there is no any signal. So this bowel is almost dead. Also, you can see in this bowel there is pneumatosis intestinalis, if you can see. Okay, if you have suspicion that this is not, then probably you can do compression. You compress the bowel or change the baby. And if the air moved or remains same, then you can conclude whether it's intramural or intraluminal. And this is a very big view, then you need to concentrate on 1 centimeter to count the signal or dots of the pulse Doppler. You can see here become circular. Here is circular, I say, and here is look like a U shape. Yeah, so this is already dead. This is going to die. So this is a hyperemic phase. This is a hyperemic phase before. And probably there will be some thinness here, and probably there will be like some intraperitoneal air also very soon. Again, the Y pattern and the circular or the ring pattern. This is after you count more than 9 color Doppler dots.
Yes.
And also you can see here dilation of the vessels of that they supply the bowel. And if you put the Doppler, I'm sure that you will find very high diastolic flow. Okay, this is one of the phases of the pathophysiology of the neck, which is hyperemic, and then death. More severe, died almost, zebra sign, where the blood is everywhere, severe inflammation, and it looks like cross lines on the bowel wall. And this is most of the time death bowel. They call it herringbone or zebra pattern. And the color Doppler is appear like valvulvi or like projections. And this is very late sign, almost like death bowel. The Doppler of ultrasound of superior mesenteric artery, very important. Superior mesenteric artery is in here. And remember, the aorta is on the right side of the vertebral cord, on the vertebrae. And on the left side is the inferior vena cava. And it comes just on anterior, the renal arteries on each side, and it comes on the anterior aspect just beside the renal artery. It's below the celiac trunk and just above the renal artery. So it's beside the suprarenal artery that supply the adrenal gland. It's above the renal artery, and it's below the celiac trunk. And then celiac trunk will become splenic artery and common hepatic artery, and the other supply of the kidney. So when you want to look at it, you put your probe or the transducer in true sagittal plane, and your marker pointed up, and then you tilt your probe a little bit to the left, pointing it toward the to the right. You tilt it toward the right, I'm sorry, and pointing to the left, to your left of the patient, a little bit. When you'll see the aorta is a big hollow structure, and you can see that the vertebral column just behind it. So you can see the vertebral column.
So I'll put the, sorry, doctor, I'll put the marker to up, then I'll tilt it to the left side of the patient.
You will put your probe in the middle, okay,
yes.
through sagittal, and your marker pointed up.
Pointer.
And then what you will do, you tilt your transducer a little bit to the right, and you will be pointing a little bit
patient.
to the left.
Ah,
because when you
the left side of the patient.
You look to the left, right, like this. So
you
see a hollow organ. It's very clear. It's while the inferior vena cava usually collapsible organ. And if you're not sure, if you want to do true coronal view on the abdomen, you will see that the aorta is a little bit behind and the inferior vena cava a little bit in the front, right? Because it's close to the vertebrae. If you go back to true, and if you put the Doppler, you'll see also the difference. It's a pure color. Either usually it will become red because it's one direction, not like the inferior vena cava have some kind of turbulence flow. Okay, and the first structure toward the heart, is the celiac trunk. The first branch toward the heart, the big branch, is the celiac trunk. The second will be your superior mesenteric, and you will see also the liver is there, because most of the celiac trunks supply the spleen and the liver. So you will see the trunk, and then you'll see branches. And then the second you will see is the superior mesenteric artery, because the rest, the renal and the suprarenal artery, comes from the left side, and usually you don't see them. Okay. The best to do is after feeding, not during or after feeding, because during feeding it will affect, because the patient is feeding, and there will be a different Doppler. It's a good study to do that.
Yes.
Okay.
Yes.
So then you can measure the diameter. The normal is 2.7 to 3.7 with mean of 3.2. The velocity, which is measured by centimeter per second, normal is here also 34 to 56 plus minus 6. These are two standard deviations from normal. And again, it's only one study. And here you can see that this is the aorta, and this is the inferior vena cava.
Yes.
And you can see here the confluence of superior mesenteric, the splenic, and before it branched to the splenic and hepatic. You can see also splenic vein, and you can see always the vein are oblique and not circular. And then you can see the superior mesenteric artery. On either side, you can see either the vein, left renal vein or left renal artery. Okay? And you can see here is the spleen, the pancreas. And you can see here is the vertebrae.
Okay.
So aorta, very big organ. And you can see here's a little bit of turbulence of flow and changing the flow after the branch. So you can see the celiac, and you can see the superior mesenteric artery. Okay, again,
yes,
celiac artery and superior mesenteric artery. Okay. Celiac artery and superior mesenteric artery, and then you can put the Doppler, and you can measure by Doppler. You can measure it by 2 DD, and not only. And you remember, we said the normal is 3.2 millimeter, ranging from 2.7 to 3.7. This is in neonate. I'm sure there will be some changes and difference with different gestation. When you look for the superior mesenteric artery, again, remember this is the celiac trunk, and branching to splenic, hepatic, and other branches of the liver before them. It's like a confluence, and you can see the superior, and you can see on either side the renal artery. So what do you look? You look for absent diastolic flow or reverse diastolic flow, and then also you measure the velocity and you measure the diameter.
Yes.
Okay, and here's, I think, the video. Here's the aorta, here's the celiac trunk, and here's the
aorta.
This is the aorta.
Yeah.
And this is the after you measure the Doppler, you can also look at the intramural gas. The intramural gas, the most difficulty is to separate it from intraluminal gas, and sometimes also intraperitoneal gas. Because when you have intramural gas, mostly you also have perforation and the gas going outside. So you can see this lumen start to thin here, and you can see some intramural gas in here. And you can see here is intraluminal gas. And you can see here is increased thickness and here is decreased thickness. You can see normal bowel wall here.
It's thickening, I think.
A little bit, but it looks like healthy to me. Look thickening, probably. And there is a fluid in here.
Yeah.
And there is also fluid.
Up and down. Yeah.
Sometimes the intramural gas are very high, so it looks like a circle of increased echogenicity of the bowel. Sometimes you find it like a bead, like this. Sometimes you find it localized in one area, like a focal area, and sometimes you find only one dot. So they have different pattern of intramural gas. Circular, the whole bowel, beaded, like a bead, focal, and sometimes only, focal or confluent in one area, and sometimes you find it only one dot.
Okay.
So you can see here intramural gas, but here intraluminal gas. Intraluminal gas. Okay, intraluminal gas. All are intraluminal gas because you can see that there is shadow here. There is reverberation of comet tail and this comet tail, but here there is no comet tail. So you can see here is intramural gas, but here is it. So once you see this, then it's clear. If you're not sure, just press a little bit or move the baby, and if it's intraluminal, it will move. Sometimes it does not move when you have poor peristalsis. So you have to make sure and repeat your ultrasound. Okay. Sometimes when it's circular, it's difficult. So is this the bowel increased echogenicity with the edema, or it's a really, when it becomes full, all the thickness of the bowel with air, becomes circular sign. It's very hard sometimes to know. But at that stage, mostly you'll see many other signs in addition to the intramural. So be careful when you see all the bowel wall are white, because this might be extensive type of intramural gas and you are about to perforate. Okay?
Okay.
So you can see here is non-circular.
Yeah. So if I'll see
Okay, so if you see it circular,
if I can see if I see the left side, sorry, if I'll check the left picture, we can see, as you said, the comet tail is going down.
Yeah.
So this is most probably, it's like, as you said, pseudo pneumatosis. It's not true.
This one is this area is not, but this is true. This is not true because you can see the comet tail going down. But in here, you can see the comet tail start from here. So this area is true. You can see this dot
here
inside, but these are not. Some of them are inside, but for example, this is intraluminal. Intramural, sorry. But this one is intraluminal.
Intramural.
Yeah. You can see this one has a comet tail.
Yeah.
You can see here lots of intramural gas. This dot, this dot, this dot, this dot, and you can see none has. You can see here, none has a comet.
Only down there is comet tail. Only down in the.
This one has comet tail, but yeah.
Yes, others no.
Others no, and all are dot in the bowels.
Correct. Yes.
Again, you can see the dots inside. This is a repetition of the picture. Okay. This is intramural gas. Okay. You can see the thinness, the thickness, and then you can see normal bowel, and you can see the thickness here, the measurement, how thick the bowel is. You can see the thickness, although this is two bowel walls, just be careful sometime when two bowel walls are. You can see the thickness in here too. And the reason for the thickness, as you remember, that the bowel wall is of 5 layers. Three of them is hypoechoic, 2 are hyperechoic. And when the hypoechoic disappear because of the edema and hemorrhage and inflammation, they become homogeneous, and that's the reason why you see it thick. But sometimes it's through thickness, it's increasing diameter also. Okay, so you measure it, and then, as you said, the normal is 1.1 to 2.6.
5.
Portal venous gas, they are either true gas in the portal vein, or sometimes you see it in the branches as dendritic echogenicity. Okay, because they are in the smaller branches. So you can see the dots here. And if you're suspicious, if you put your Doppler on it, you will see changing color, not only blue and red, you will see changing color. Turbulence of the
flow. So this changing color is pathological.
Correct, because like let's assume this is air, but you think it might be biliary system, or it might be a hollow organ, or it might be a bowel. So if you put a Doppler on it, you'll see color change. So you know this is vessels, all right? Normally, you don't see turbulence of the flow in portal because the flow are very luminal, because there is no active pump inside the liver. So when it becomes not laminar and it becomes turbulent, then there is something inside it causes the turbulence. So you put the Doppler and you don't see clear red or blue. You will see that there is change in color. You'll see green, you'll see yellow, you'll see orange. So you'll see turbulence of color. You know that this is vessels, and you'll know that there is something wrong inside it. And you can see there is dots in here, and then dendritic in the small branches of portal veins. If you look in here, you'll see the gas moving.
Yeah.
If you're suspicious, and this is a hollow organ or artifact, put your Doppler.
Yes. And of course, all this white is the gases in the liver.
Probably, yeah. But remember to use the lowest contrast. Okay, I mean, the lowest whitenings, of the picture. Okay, that's the most important.
Whitening to be more white. Okay.
Less white, more dark.
Less white. Okay.
Lowest contrast. We mean you turn it to become more, before it becomes totally black. So you will, to avoid confusion between increasing echogenicity of normal structure and really whitening air.
Okay.
You can see this is a little bit of increased echogenicity, probably because they are taking the picture from 2 screens. So this is not a good way. Although it's very clear here, there is air, but it's very white. So you try to make it black, but it's very clear. So try to turn it. This is not the correct way to, but if you continue looking, you'll see that there is a very black area of the bladder, which means the contrast is not very high. But it looks very high contrast because they are picturing from 2 screens, like one screen to another, and there is reflection. So this is not a good contrast. You have to drop the contrast if the picture is not like this. You can see that area become white, the bladder appeared. Mostly this is is a good contrast because the bladder looks very black. But again, there is shadowing, like contrast, because they are picturing from one screen to another.
Okay.
This is very good contrast, you see. You can see
there is air, I think, and comet tail in the
there's air,
right.
and you can see this was like it wasn't. This is he put the Doppler, and this is a vessels, not a hollow organ, and there is turbulence of the flow. So if you do it again, there is air inside this, and you want to make sure, is this truly a hollow organ or it's a vessels? Because it was so big. So he put the Doppler on it to make sure this is not a hollow organ. And his contrast is very good. You can see that this is a true vessels, and there is turbulence of flow. It's not a clear yellow, clear red and blue. This is a dendritic type of portal venous gas distributed in the small portal veins. Looks like lung, looks like ground glass appearance of the lung. You can see perforation here. You can see perforation, you can see fluid, and you can see air bubbling. And it's moving to become below the skin. Do you see it? The bowel air.
Yeah, I can see.
Bowel wall air, and then perforation. And then you can see bubbling, moving up until the skin. And there is a fluid outside. So very nice picture. Yeah. There is perforation, there is portal, there is intraperitoneal gas, and there is intraperitoneal fluid. There is here also intraperitoneal gas. There is nothing else give you this picture other than intraperitoneal gas.
Yeah.
And you can see there is no shadowing, no artifact, because it's surrounded by fluid.
Yeah.
This is supposed to be air, free air. I don't see it very clear, but it's not from my, it's from YouTube. You can see the abdominal wall. You can see fluid here. This is inside. The fluid appears to be black, but also you can see that there is some tissue inside it. So it looks like more turbid fluid. So it looks like there is a debris and there is perforation probably, and stool and other stuff appear, and maybe inflammatory materials. You can see this is the liver.
Yes.
So this is the picture between the liver and the abdominal wall. And you can see there is also here some septi or some material that's stuck, and there is fluid in here and fluid in here. So the fluid appears to be black, remember that. Where you look at the fluid, you look beside the bladder. So when you do, of course you search the entire abdomen, but you look beside the bladder. So when you do left lower or right lower,
there's fluid.
And you look between the abdominal wall and liver, this is spleen, this is kidney, sorry. Between the liver and the kidney, liver and kidney, between spleen and the kidney, and sometimes you can see it between the bowel walls itself. You can see the kidney, and you can see air. Here's the liver, kidney, and air in between. And not air, sorry, fluid. Fluid, I'm sorry, fluid. Very clear, huh? Big amount.
Yes.
Which means that you need to see the fluid between two solid organs. So bowel and bowel, abdominal wall and liver, liver and spleen, liver and kidney on either side of the bladder. And we are done.